common baldness that you see in men and women, the non-scarring variety. If you look at the scarring hair loss, there has been an injury at the level of the follicle.
Okay.
Smoking has been found to be a very big factor in preponing the onset of hair loss in genetically predisposed individuals. There was one paper from Bangalore said as a conclusion that there is no correlation between hair fall and the mineral content of the water. Water per se in that same individual will not have an impact on the beard or mustache. Why is it having impact only on the scalp? And it's something to be thought about. First, bifurcate the issue. Hair loss and hair fall are two different entities.
Maybe you could touch upon, these non-medical treatment options. We know that minoxidil was something that was there for a long time. That there's finasteride, there is PRP, and now there are new drugs like tofacitinib. Maybe you want to just touch upon that before we, go to a final segment of surgical, the non-surgical treatment.
The thing about all the medical treatments for pattern hair loss are serendipitous in their, being available, right? Minoxidil was a drug, oral medication used to treat refractory hypertension.
Right, correct.
And they found an increased amount of hair growth on the body, which happened to patients who are on this for a prolonged period of time.
Correct.
See, minoxidil was a drug used to treat high blood pressure, which was not responding to other medications.
Right.
And they found that these patients who were on the tablet minoxidil were having excessive hair growth on their body.
Right.
They formulated a version which would work without causing an effect on the blood pressure.
Right.
And that was when minoxidil was approved in the 80s as a treatment for hair loss, pattern hair loss. Initially, it was 2% and later on 5%. And Finasteride was a drug which was originally approved for treatment of prostate enlargement.
Okay.
Because the same enzyme, 5-alpha-reductase type 2, which plays a role in prostate enlargement, also plays a role in male pattern hair loss.
Right.
So this was a direct inhibitor of the 5-alpha-reductase enzyme, and that plays a role in reversing or stabilizing the hair loss in men. So both these drugs, minoxidil in the 80s and finasteride in the late 90s, were given FDA approval.
Okay.
And to date, they are the only two drugs with an approval. And I can tell you from a clinical perspective, having used these drugs in my practice, I found them to be the only effective medications for male and female pattern hair loss. Finasteride, of course, not used in women,
right?
But these drugs. The importance here is counseling, because patients don't understand. They expect that if they apply minoxidil today, they want to see hair back tomorrow.
Right.
Both of them have a latent period of about 4 to 6 months before you start seeing any change.
Okay.
And with minoxidil, the worser thing is that initial few weeks, there will be increased hair fall, which is natural. And I tell the patient, if you have hair fall, I'll be happy.
Right.
Because that day he's going to respond.
Right.
So the important thing is that once you counsel them and tell them, these are the two drugs, they're effective, just be patient. For us, we take pictures of the patient at every single visit.
Sure.
In the same format, in the same position. And when the patient sees objectively the improvement, see, somebody saying something is one thing, but objectively seeing a difference,
right,
where there is better coverage or, improved volume, they are very happy about it. And then they become very, very particular about being compliant.
Is this something that they have to apply topically for the rest of their lives?
I would say that since the problem is going to be something that is going to progress, the treatment also will be long-term, or I would say open-ended. So if the patient asks me, is this for life? I said, till the time your hair is relevant to you.
Okay.
It is as simple as that. The day you feel that it is not important, don't use it.
But I've also read about side effects of these drugs. Maybe you can touch upon that.
Yeah. See, any drug like you would know,
right,
which has a benefit in a small percentage of patients, has an adverse effect.
Right.
Let's talk about minoxidil. Minoxidil is a very poorly soluble substance. So to keep it in solution and stable, it has to be combined with a mixture of water, alcohol, and propylene glycol. So when you use these excipients, they are obviously going to have some kind of a drying effect or irritational effects on the skin. Today we have formulations which have replaced some of these solvents. But to my mind, I feel the original composition of minoxidil is by far the best in terms of efficacy. Minoxidil works as a prodrug. It is not the actual drug. So minoxidil needs to be converted to minoxidil sulfate. Now, where does this conversion happen? In the hair follicle, outer root sheath of the hair follicle. When it goes through the dermis, when it's absorbed from the scalp, this enzyme converts minoxidil to minoxidil sulfate, and that is when it has its effect. Now, the trick here is that the expression of sulfotransferase enzyme is very different in the population. Somebody may have no sulfotransferase, somebody have poorly expressed, somebody have very well expressed sulfotransferase. So that will decide the efficacy of minoxidil and the side effects. Side effects are basically cutaneous because they are on contact. So the contact dermatitis, irritation is going to be standard.
Does that affect blood pressure? Because that is what was mentioned.
Generally, with the percentage that is used, the blood levels of minoxidil are very far away from the blood levels that can actually cause a vascular response.
Right. And in finasteride, I mean, we've been told about, sexual problems or depression. What has been your experience?
See, I believe that there is significant nocebo effect, just like you have a placebo effect. This is interesting because there was actually a study done. They had two groups of patients. One group, they actually told all the adverse effects, and one group, they didn't tell them anything. Randomly selected patients. So the group which was told about it had a much higher, statistically significant higher incidence of adverse effects.
One has to be aware of, I'm okay.
Yes, that is one thing.
Right.
Second thing, there is an issue. I am not disputing the fact that there are adverse effects, but they are entirely reversible on stopping the medication. However, in 2012 or 2013, the US FDA added a paragraph in the package insert for the Finasteride cream, where they said they have received post-marketing information from patients that there were adverse effects which persisted even after discontinuing the tablet. Now, what happens is there is certain mice studies have shown an element of depression is possible in the mice that were given finasteride. But in humans, that could not be extrapolated. So I, as a doctor, give this entire information to the patient, telling them everything clearly. Sure. Share with them literature. See, it's important that literature comes from a consensus source and not from an individual. Right. So giving them that information is critical. And apart from that information, you tell them examples of patients who have been on the drug, right, and show them the results. That helps them tide over the anxiety of the adverse effects. Okay. But if a patient has had issues with mental health or has had issues with his sexual life, I do not prescribe finasteride. Okay. Moreover, finasteride now in India is available, it's been available for almost 15 years in a topical version. Okay. Now, the important thing here is that the blood levels of finasteride when taken in the oral form compared to blood levels of the finasteride when applied topically, there's a difference of almost 10 times.
Okay.
So I'm extrapolating the fact that if the drug exposure is less, the possibility of adverse effects also goes down. I am not saying it will not happen, but the possibility definitely.
Efficacy remains the same.
Efficacy remains to a large extent. And I would not say it's 100%, but even if it is 70%, it's a big plus.
Right. 70% the efficacy and 10% the side effects.
It is much less than that.
Right. Now that you mentioned topical, I mean, in India, we are used to especially go for a haircut, follow that up with a nice head massage. Grandmothers say, come, I'll put some coconut oil or whatever. What's the actual? Is that really a truth or it's a myth?
Let's take two things separately. Oiling the scalp is a culture that belongs to the subcontinent only. We don't see the concept of hair oils anywhere else. Okay? It is not there. It is unique to our subcontinent. Oil, when it is applied, by virtue of its molecular size, it cannot reach the follicle. It can reach only the shaft.
Okay.
And coconut oil is the only oil which can penetrate intercuticular spaces and reach deeper to give it a pre-conditioning effect.
Okay.
Other than that, there is no role for oils. It can be used as a pre-wash conditioner. It has no role on hair growth, hair fall, graying, nothing. No role whatsoever. Of the various oils that were studied, the vegetable oils, coconut oil was ideal as a pre-wash conditioner. So applying oil an hour before hair wash is far better than leaving it on after your wash.
Right.
Because after the wash, it becomes a magnet. It will attract all the possible dust which will come and adhere to it. And
I remember my grandmother used to say, "Raat ko I'll apply and then you sleep with it the next day in the morning."
that is still okay because you're not getting into a dusty atmosphere.
Right.
But 1 hour is good enough for it to work its magic.
But that's only like a conditioner.
Pre-wash condition. And with regard to the massage is a feel good. Any muscle that is massaged will relax.
Correct.
Most of us, by virtue of our lifestyles, will have some amount of stress. This stress generally goes to the temporalis, frontalis, or the occipitalis muscle. There is no muscle here. It's only aponeurosis.
Right.
So massaging anything here is of no use. The massage has to be here or here or here.
Correct.
So
it's not that massaging will increase the blood circulation and things like that.
See, this thing about blood circulation, they have done these studies. They have tried to see whether lack of blood supply is a cause for hair loss. They found that transcutaneous oxygen concentration in the bald area was slightly less than in the hair-bearing area.
Okay.
So there is one major conclusion would have been that oxygen this is less oxygen. That is why there is hair loss.
Right.
But you look at it deeper, the function of the follicle or the hair was originally thermoregulation.
Correct. Okay.
So the presence of hair provided an insulation for either loss of temperature or from the heat outside or from the cold outside. So when you have loss of hair, that thermoregulation is lost. So the temperature of the bald skin will be slightly lower than that of the hair-bearing skin. So lower the temperature, there will be vasoconstriction,
right,
which will account for the lower transcutaneous.
So I am likely to feel more cold in Kashmir than you will.
No. I think the temperature of your skin in the non-hair-bearing area will be slightly less.
But it's not that I will feel more cold, so I have to wear a skull cap.
See, because evolutionary perspective, if you see the function, once we got civilized, we would take care of our environment and ourselves. That is why one of the ways that I think I tell patients also that hair loss would be evolutionary. So a person using hair is more evolved. And it's a point. If you think deeply, you see we have shed hair everywhere else.
Right.
As a part of evolution.
Correct.
True. So because we are able to manage our environment, we don't need that. It's become a vestigial.
Right.
Because hair on the scalp is important socially and
aesthetically.
Aesthetically, it is way you look at it. But technically, you don't need it.
Interesting point. Before we go into the last segment, maybe quickly you could touch upon your experience with PRP and with the new drug that you mentioned to me, Tofacitinib.
Okay. PRP basically means platelet-rich blood. So platelets are the first responders to any. If suppose you have a cut here, the first thing is that there will be a platelet concentration there, and they lyse, and then they release growth factor. This is basically to promote healing.
Right.
So it is a preservatory kind of a response. Now, when you collect blood and centrifuge it, you can concentrate platelets in a small part of that entire collection. And the logic was that if I'm able to deliver these growth factors to the necessary affected area, it might benefit the hair follicle. That was the rationale behind it.
Sure.
And it did come in a very logical way. It came because it was being used in other specialties, like orthopedics, dentistry, where one place that I feel it is very relevant is when you're treating foot ulcers in diabetics or
Sure.
Make a big difference.
Right.
But my understanding of its importance in hair loss, I feel it is not so rationalized for me to advocate it. Having been part of a study, I didn't see the change. Now, we had two groups, one which we used conventional treatments of minoxidil and finasteride, and one which we used the platelet lysate. And we found that the difference between the results was huge. In fact, most patients of the platelet lysate group had no response or very minimal response to speak of.
Okay.
And because the sample size was small, I could not even say that that small response is significant.
Sure.
But there are certain growth factors, like there is TGF beta,
Right.
which is a part of the growth factor that are cytokines and everything. TGF beta is supposed to be a pro-apoptotic factor, means it is something that slows down the follicle. So why would I inject that in a person who's already having a problem? The thing is that it has a huge placebo effect for patients. And most doctors, I feel, do it because patients want. There are very few doctors who have been able to show a very good, large sample sized,
That's so important that
randomized study to show that it is effective.
it's good to know that there are people like you also tell people what to do, but what not to do.
Yes.
And maybe about the new drug.
Yeah. See, the thing is that these immunomodulatory drugs that have come into play,
Right.
specifically for conditions like the alopecia areata, there have been a lot of publications which have used the JAK inhibitors, tofacitinib, for in an oral form as well as the topical form for treatment of this, and they have had promising results. It's probably too early to say that it is going to be the one and these.
Right.
But we need some time before we can say that this could be a part of mainstream therapy for alopecia.
Okay. But it's something which is coming up, you think?
It's coming up. Yes.
Right. And I think since you spoke about these, drugs that are available, are some OTC and are they prescription? Do people, can they just go and take it and apply it? I mean, how should they, what are the do's and don'ts for these drugs?
I would not recommend anybody to use this drug without consulting a doctor.
Right.
And though minoxidil is sold over the counter in the United States, in India, there is no such understanding as of now. So primarily finasteride and tofacitinib, they are only prescription drugs. And I feel that even if you are using minoxidil, it would be worthwhile or safer to consult a doctor before you think of using it, because you need to understand that's the problem that you have, whether it fits in
Correct.
to the solution that you're trying to.
As you had explained.
Yes.
Right. Absolutely. Thank you. Let's take a break here as we enter the last section. Let's energize ourselves with some dokla.
Thank you. Thank you.
I know you always prefer to have cooked snacks. Is there a reason for that you prefer cooked snacks?
It's just that as children, we have eaten everything. Even when we were doing our medical education.
Right.
It is just over the recent past that, you have tended to be skeptical of raw food.
Right.
I generally tend to avoid it. But otherwise, cooked food is okay. It's nothing hard and fast, but if possible, I try and avoid.
Unless you know the source, if it is probably made at home or something like that.
If I'm in somebody's house, then I eat.
Right. I know that many people in my friend circle, whenever they thought of hair transplant surgery, always thought of either Turkey or Greece earlier on. And they would always think, am I the right candidate? Can I afford it? Best there. But I think gradually over a period of time, India has now become a hub as well. Maybe you could, quickly just share with us the evolution, how hair transplant surgery has evolved and what is the future looking like?
You'll be surprised to know that the technology that we are using today, which we are harvesting the hair follicle 1 unit at a time using the cylindrical punch, right, was actually practiced by the Japanese during the Second World War. Okay. The unfortunate part was that they had published this Japanese literature, which was not shared with the entire world till much later. Okay. Now, this was in the late 1930s and early 1940s, where they published this. For a very long time, there was no treatment available for this. Then in the 60s, an American dermatologist looked at using punches of a much bigger size to borrow from the back of the head. Now, therein lies a big thing, because there was something known as a property of donor dominance. The whole logic of hair transplant is based on the property of donor dominance. That means follicles from the back of the head are supposed to last your lifetime.
Correct.
If I were to move these follicles entirely to a new area, they will continue to grow there irrespective of any influence in that area. That was the property of donor dominance on which hair transplant was based. So this was known as punch grafting, which was very popular in the 60s. The problem with this grafting was that it created large plugs of hair. If you have seen plastic dolls, they will have these clumps of hair coming out. So it gives what is known as a doll's hair appearance or cornrows, it would create rows, which was not very aesthetically pleasing. Around the same time in the 70s and 80s, a technique of approaching baldness in a different way. The person is bald, you would start reducing the bald area by excising the bald area and stitching the hair-bearing area closer. So this was known as scalp reduction or alopecia reduction. It has its own, it was technically a quite morbid procedure and needed a hospital, stay and was painful.
Right.
But the worst part was that the problem was not solved because the scar would stretch back and you would end up having the same problem all over again.
Right.
Then there was an era of scalp flaps where they would harvest hair-bearing skin and move it to cover the bald area. Entire flap with its blood supply.
Sure.
So the problem was that the direction of hair would be uneasy. The hair is growing down here, you put it back here, it is still going backwards. So that was the problem. And around this time, they started experimenting with what is known as the micrografts and mini grafts. So they would harvest an ellipse of skin from the back of the head, stitch it up, and dissect the strip into smaller units and implant them. As the graft size started getting smaller, the results became more aesthetic, more natural.
Right.
Then there was the discovery of the follicular unit, where if you see hair on our scalp grows in groups.
Right.
And this is not only an anatomic but a physiological entity. So preserving this follicular unit in its natural form and moving it to the new area gave a lot of naturalness to the result. So this was the basis of follicular unit micrografting, which started in the 80s and became very popular in the 90s, in which a strip of scalp was harvested and under magnification dissected into individual follicular units, which were then implanted in the bald area. The problem with this technique was you would need surgical expertise to do the harvesting and suturing and everything. You would need a better infrastructure in terms of trained technicians and magnifying aids like video microscopes. At the end of the day, patient would have a linear scar at the back of the head, which would be regularly concealed by the overlying hair. Now, if the person decided to shave his head or go for a very short haircut or a buzz cut, this scar will be visible. Which in spite of the best of the scars, there would still be some telltale evidence that there was a scar. So this was a deterring factor. Around the same time, they started coming out with the logic of harvesting individual follicular units using a cylindrical punch that is of the size of 0.91 millimeter, which would leave very small and still give the naturalness to the implanted area. And that really took off in the early 2000s.
Right.
And today has replaced the follicular unit grafting or the strip harvest as a major technique of donor harvest. So what happened in Turkey was that they could delegate a lot of this work to technicians who are not doctors.
Correct.
So they had a bigger team. They were the original people who started doing manual punches and they started using implanters and it became popular there. And gradually from Greece, it spread to Turkey. And once it set up in Turkey, they started having hair transplant clinics at every nook and corner. It became kind of an assembly line process.
Sure.
Where there would be 10 patients simultaneously undergoing the surgery.
Right.
But the problem here was there would be only one doctor looking at all these patients. So there was an element of significant delegation of clinical steps of the procedure to non-doctors,
Non-medical
people, personnel. And what worked as an advantage is that the same technique which was available in the United States or the United Kingdom was far more expensive because it was a labor-intensive process.
Right.
It was very expensive. So these people offered it at a much cheaper rate along with travel and tourism packages, which made it very ideal. But the problem was that the patient was consulted online and it was only based on pictures and they would give the decision advice only on the pictures,
virtually,
which I feel is really not in interest of the patient.
Right.
So this became the hub, and even today it is still a major hub, but there are a lot of horror stories that come out of Turkey, and these have been published in scientific journals as well.
Sure.
So today, the ISHRS, which is the international body, or the AHRS, which is the Indian body, are strongly condemning delegating this work to technicians.
Right.
There is certain amount of work which can be done by the technicians, like putting in the grafts in the pre-made recipient area.
Okay.
They are not supposed to be making any incisions on the body or planning the airline or giving local anesthesia. Right. But in Turkey, everything is done by technicians. To a large extent, not in all the clinics. There are some very good clinics.
Sure.
But the ones that work on a mass scale will have this kind of a...
And patients will always find it difficult to know which
they
one.
will not know.
Correct.
And that is the problem. Today in India, also this issue has come up because we have dentists, we have homeopaths, Ayurvedic doctors, all practicing hair transplant.
Really?
So in India also it has become like a turnkey approach. Tomorrow you set up a clinic and put up a board that you offer hair transplant. We call in the team, they will come and do your process for you.
Right.
And you pay them their fees, you can collect what you want from the patient. Now, the thing is that some of the teams will be pretty good in the sense of delivering grafts to the implanted areas, having hair, but they may not be aesthetically correct. They will have abnormal hairlines, unaesthetic hairlines. They may have over-harvesting of the donor area where you leave the patient with very thin or scanty hair on the back, which is again a problem.
Right.
I don't believe we should replace one deficit for another deficit.
Correct.
The trick is in borrowing only that much, which can fulfill some extent of the problem, but without creating a second problem.
Can you borrow hair from any other part of the body other than back of the head?
Yes, you can. The character of the hair in different parts of the body is really different.
Right.
Because you don't need to go in for a haircut for your torso hair. Beard, you need to shave.
Right.
Beard is one of the most sought after sources for donor hair, especially the shadow area.
Right.
So this is where even if there are pinpoint scars, they are not going to be so visible. The torso is another place where you can get hair. But each of these will have their own pros and cons.
Sure.
And they cannot be used in all aspects, all parts of the... Like you would not use the beard for the hairline because it will give a very odd looking hairline.
Right.
And this is going to just give you some kind of a feeling, some kind of a volume,
Sure.
which is not the same as the naturalness of a scalp hair. But you can augment the scalp hair requirements with these non-scalp areas.
Right.
And not everyone is a candidate for non-scalp hair.
Sure. So coming to that, I mean, how do you decide whether a person is a candidate for hair transplant surgery or not? Is there any criteria? Suppose I come and say, is there a qualifying criteria to select a patient and say, no, you are a candidate or you are not a candidate?
See, it is like this. Technically, anybody who has hair loss, I can put in hair where there is no hair,
Right.
at least at some part.
Right.
The important thing about this is hair loss is a non-medical situation, not an illness.
Correct.
So here, I need to understand patient's expectations.
Sure.
If those expectations can be met by the available donor hair in him, then he is a candidate.
Right.
If his expectations are far exceeding what his donor area can give, then he's not a candidate. This is as simple as I can put it.
Beautiful.
But then there are areas where you can, give the patient not exactly what he wants, but something close to it.
Right.
So getting his expectation to the region that you can deliver is the key in counseling. The idea is not to sell the procedure to him. The idea is to tell him that this is one option that can get you this much.
Achieve the expectation.
Yeah. So if you're okay with this, you should go ahead with it.
Right.
So when I see a patient, I tell them everything that is possible,
Sure.
including using a hairpiece.
Okay.
So they know what they are getting in. They should know the pros and cons of using the medications. They should know the pros and cons of a hair transplant. They should know pros and cons of using a hairpiece. Everything. Once they can think it over, they sleep over it, come back, and then we decide what can be done.
Is it a very painful procedure for the patient? Hair transplant surgery?
I would never say it is a painless, but I would not say it is very painful also.
Sure.
See, it is about kind of setting their expectations where the procedure is done.
Right.
Pain is a very crucial thing. You have been to a dentist. I don't know.
Yes.
You will have been to a dentist.
Right.
So suppose you undergo the root canal. The first exposure to pain is when the local anesthetic is given.
Correct.
You feel the stinging pain.
Correct.
Once that works, all you feel is a vibration of the drill, of whatever is being done, but you don't feel the pain. If you look at it from the perspective of the scalp or the hair transplant, you will feel the pain when I'm injecting the anesthetic.
Right.
The only thing, the difference between a root canal is at 1 point or maybe 2 points. Here there will be hundreds of points,
right,
where you inject. But what I do is use the gate control theory of pain to our advantage. So if you create two stimuli in the same dermatome, one vibratory, other painful, the vibratory stimulus reaches the brain first. So it kind of blocks the gate. So the pain doesn't reach the brain that quickly. The patient perceives a little less pain.
Right.
It's not painless, less pain.
Tolerable.
Yes. And we use a combination of anesthetics, one long acting, one short acting,
Sure.
so that I can use both of these in an optimal dosage without exceeding the dose. And post-operatively also, with this technique, I don't use anything other than paracetamol.
Okay.
That is sufficient to take care of the pain. But it is the way you deliver the anesthesia. And I give an anesthetic dose at the end of the procedure. It makes a difference to the patient. But yes, it is not a painless.
Sure.
But it is something that you can. One thing that is important is the amount of pain you perceive is inversely proportional to your motivation to undergo the procedure.
Very nicely said.
So if you are very motivated, because not stealing.
Right.
If you are a doubting Thomas, you feel a lot of.
And is there a success rate to this? I mean, what percentage do you see success rate? And what is the measure of success? And for some reason, if it doesn't work, I mean, what's been your experience on that?
Success can be left at 2 years. At an anatomical level, because like if I moved 100 follicles to the front,
Right.
short of 100, I'm expecting at least 90 to grow.
Okay.
This is the conservative figure.
Okay.
It will be more than that.
Right.
But when I talk to the patient, I tell this anything between 90 and 95 will grow.
Correct.
This is in terms of the sheer anatomical or surgical assessment.
Sure.
But success of a patient depends on patient's happiness. There is vanity that thrives with surgery.
Sure.
The patient is happy. There are some patients where I feel that I could have done more, but patient is thrilled with the results. And there are some patients where I have done really a lot and I'm content with the results. Patient is still asking for some more.
Right.
So therein lies the difference.
Sure.
But your question about not growing anything,
Right.
very, very rare.
Okay.
It's very rare.
Okay.
If you are in charge of the process and you have chosen your patient, then it's unlikely.
Right.
But in the field of medicine, you cannot.
There are no
No, there are no.
Correct. Correct. No, but the fact is that because here in your setup, you are doing everything yourself. And that's why you do, I think, one surgery a day.
I don't, because it takes about 6 to 8 hours. And I feel that you have to be optimally positioning yourself mentally and physically to do this process. And because delegation is an important aspect, but if I'm motivated, I'm doing over 65 to 70% of the procedure over 8 hours.
Right.
I think it is not possible humanly to do a repeat of that after that short. So I don't do surgeries.
Quality over quantity, I think it's.
So it's each one for himself. There are people who can do surgeries in a day. Sure. They are okay with it physically and mentally, that's fine.
Sure. And typically after the surgery is done, how long does it take for the effect to show itself?
See, once you put in the grafts, there are scabs, visible marks, some pain, some swelling, which is all gone by 2 weeks to 3 weeks time.
Okay.
Then there is a period of time when there is no change. There is nothing showing up.
Right.
Around 3 to 4 months later, roughly around 4 months, is when the follicles start producing the hair.
Right.
The planted follicles. By about 8th month, 7 to 8 months, you'll see about good 75-80% of the result. And I would say 12 to 18 months is when you see the full outcome.
Okay.
And this is told to the patient
Right.
at the outset.
And at this period of 12 months after surgery, difficult for the patient to manage? I mean, is there any precondition or anything that they have to do to maintain?
See, basically, like I said, my approach is using the medications and the transplant. So, 3 to 4 weeks after the surgery, I start them on the medication that they count for all of the 2 to 3 months, especially those who are in Bombay. Those who are not in Bombay, they connect with me through email or video consult.
Sure.
And we check the progress and everything. But most of our patients, by 8 months or 9 months, will see a reasonable change to their appearance.
Wonderful. Wonderful. So before we end, I want you to share few common myths that you have, been encountered with, and if you want to sort of dispel those myths, what would those common myths be? Like you pluck one hair and it'll never grow again, or if you shave more often, then it'll grow thicker. If you wear a helmet, you might lose hair in the center. These are some
common things that I keep. If you're wearing a cap, a hat, or a helmet, as long as it is not constrictive of the blood supply, it should not cause any problem.
Okay.
The hair is
Sure.
what you go about the massage.
Yeah, oil, I think that was clearly.
That is the hormone change now.
Right.
So basically, what happens is when the virgin hair grows, it is tapered at the tip, and you will see it in that box of it. When I cut it at the level of the skin, it grow as a dog. So it will appear thicker. But shaving per se does not alter the follicle which is beneath the skin.
Sure.
So there is no change. There is no excess growth. People think by shaving their hair, they will get their hair back.
Right.
That is also a myth. Nothing will change. So shaving does not increase the hair.
Sure. And if people want to reach out to you, how should they connect with you?
Through email.
Can you share your website or your clinic's name? It's Hair Revive, I think.
Hairrevive.com is my website.
Right. I think this has been I would say, a hair-raising experience.
My pleasure.
And, I can't wait for it to, come out so we can, have the audience actually be so much better informed about it. Thank you so much, Sandeep, for doing this for me.